Hello, everyone. Welcome to Doctors Making a Difference. I'm your host, Dr. Peter Crane. I'm a physician in rural Idaho where I've been in practice since 2011. Over the past couple of years, I've had the opportunity to be both a physician and a patient, and I've been so thankful for the doctors and other healthcare professionals who have helped me. I invite you to join us as we highlight physicians around the world who are making a difference in their communities and with their patients. Our goal is to give physicians and other healthcare professionals the tools they need to be successful in medicine, in finances, and in life. What we do makes a tremendous difference for our patients and our communities. Please go to your podcast service or YouTube channel and give us a 5-star review and hit the like or subscribe button. It helps get the message out to others. You can also check out more content on our website, doctorsmakingadifference.com. Finally, if you would like to be on the show or have any questions or topics that you feel should be addressed on the show, please contact me. The easiest way to get in contact is to subscribe to the newsletter and then hit reply to any of the newsletter emails. Welcome to the Doctors Making a Difference podcast. Hello, everyone. Today on the podcast, we've got Dr. Lance Jacobson and physical therapist Dr. Will Crane, and we're going to kind of talk about the intersection of those two doctors and kind of correlate how this all ties together. But Lance, why don't you introduce yourself first to the audience?
Yeah, hi. So Lance Jacobson, I am an orthopedic trauma surgeon up in Idaho Falls, Idaho, practicing about 2 hours from where I grew up in Bear Lake, Idaho.
It's pretty cool. Yeah. So Will, why don't you tell them who you are?
Yeah, so I'm Will. I'm a physical therapist, but I'm kind of the intersecting point here because I had to have Lance put me back together this last summer after a four-wheeler wreck, and so I I enjoy much more being on the giving end of healthcare rather than the receiving end, and so anyway, it was good to connect with Lance there, and so I'm a physical therapist. I've been practicing for about 13 years, and I also do some online education, so I teach people how to prepare for and pass their board exams. So a little bit of clinic work as well as some education work, and I continue to practice as a physical therapist to today.
Awesome. No, thank you. So I want to jump back into that story about how Lance had to put you back together. But Lance, just to kind of highlight a little bit, we've shared a patient or two along the way. We all grew up in the same community, and it's kind of interesting to talk to people that have a shared background. And Lance, if I've got this right, I think you're one of just a couple of people that in Southeastern Idaho that do pelvic trauma surgery. Is that right?
Yeah, that's correct. When I moved to Idaho Falls, I was one of two in southeastern Idaho. And as the population has grown over the last 7 years since I've been here, we've picked up a few more. So there's two orthopedic trauma surgeons in Pocatello. There's me in Idaho Falls, and that pretty well wraps it up for southeastern Idaho. Obviously, you get to Boise, you pick up a few more, and you can go south to Salt Lake City and get some more. But in southeastern Idaho, there's now three of us.
Yeah, well, I know. Whenever I have someone that comes to the ER that has had a big pelvic trauma, it's a pretty short list of people that we can call. I'm like, well, it's either our friend Dr. Jacobson or one of the guys there in Pocatello. So it's a needed thing, and in the hour of need, people really need that. So just for a minute, kind of walk through this, Lance. Just a lot of the listeners on this program are early career doctors or residents. Tell me a little bit about that pathway to become, to choose to become a doctor, and then choosing orthopedics and specifically orthopedic trauma. I'm interested in how you chose that.
Yeah, definitely. So my career into medicine in general started quite early, probably pretty unique. My father was in healthcare administration, and so I was introduced to healthcare pretty early on and knew that that's probably the route that I wanted to go. And so at the age of, I think I was 14 when I approached him and asked if there was an opportunity that I could shadow somebody or just get my feet wet and just kind of see what healthcare looked like. Because after watching him and his job in administration go into meetings, I knew that's not what I wanted to do.
That's
I
not
wanted
true.
to do something else. So he had a friend there in the hospital who was an orthopedic surgeon, and gave me the opportunity to shadow him as a 13-year-old and go and see some of his surgeries as well as follow him through the patients. And it really jumped out at me the gratitude that patients had for him and for what he did. And so it was at that point that I knew I wanted to be in medicine. And probably at 16, I joined a locally supported certified nurse's assistant course and graduated from that 6 months later, and then started working as a CNA when I was 18 and out of college or out of high school, and I used that to pay for my way through college, and then that was through Logan, and then went to Milwaukee and did medical school at the Medical College of Wisconsin, and then from there, I had already been interested in orthopedics from what I had done in Bear Lake, but that was affirmed when I was in medical school, just through the rotations there, that orthopedics was definitely where I wanted to be. And, that probably come from the fact that I spent a fair bit of time working on houses and doing construction work. And I knew I enjoyed working with my hands. And when you put medicine and carpentry together, there's only a few specialties that come out there, and orthopedics probably being the main one. So then went to Salt Lake to the University of Utah, where I started my orthopedic residency. And, it seems like early in residency, in orthopedic residency, almost every resident thinks they want to do trauma. And I think the reason for that is that that's the first one where you really get your hands dirty. Because it's like you said, it's emergent care. There's so many hands that are needed that sometimes you can't be too picky about how educated those hands are. So everybody's got to jump in. And so even an intern who doesn't know a whole lot about orthopedics is still going to get his hands dirty, because we need somebody to hold things out of the way or hold limbs while you put on casts or splints. And so early on, I think everybody's interested in trauma, and that was certainly true for me. But then as residency progresses and you see the other specialties, you start to see the attractiveness of schedules that are more predictable.
Right.
And you start to get interest in other specialties. But for me, the thing that jumped out about trauma was that it does two things. Number one, you get to meet people on the worst day of their life. And it's a unique experience, and it's either one that people don't enjoy or one that you jump into. And I certainly jumped into it. I loved meeting people on the worst day of their life, not because you see the misery that people go through, but you're given an opportunity to help people in that moment of need, when they feel like they have no control over anything. And it's a unique opportunity as a physician to be able to help them in that moment. And the second thing that I think that it does is it makes you grateful for what you have. It doesn't matter how bad a day you're having; things can be going terribly. But when you meet the individual who just got thrown off their ATV and crushed, it makes it pretty hard to feel bad about how your day's going. So that kind of stemmed my interest in trauma, those two things, those two unique opportunities. And I knew that being a local small town Idaho boy, that's what I needed to get back to. I needed to get back to small town Idaho. And I reached out to the hospitals up here in Southeastern Idaho and asked them if there was a need for orthopedic trauma, because that was where my interest was. And it was a resounding yes, that they had a great need for orthopedic trauma. I knew early in my career that my goal was to bring subspecialty level care back to Idaho. We have a unique opportunity living where we do, and we love living where we do. And we, in general, don't enjoy going to big cities if we can avoid it. And a lot of the times in healthcare, we don't have subspecialty level care that can keep us close to home, and we have to travel. And my goal was to bring that level of care to smaller communities and hopefully keep people closer to home.
Well, it's pretty neat, and just as a little bit of backdrop, we all three of us grew up in the same community, which is a pretty small rural community, and so Lance's dad was my boss for the first several years of my career, which is pretty neat. He persisted in that administrative role for a long time, probably longer than most, and I appreciated his insight and wisdom. And I think that's pretty cool, Lance. It matched your particular interest and your talents with a need, in kind of a whole region of a state that's pretty rural, and I think that's neat. So I want to jump into let me have William introduce himself just a little bit more. Kind of that, you are the unfortunate victim in this story. Will's given consent to talk about his medical story, but like you said, you've been a physical therapist for quite a few years and have helped people recover from lots of traumas from various things. And like you said, it's a lot more fun to be on the providing side of it, the helping side, rather than the receiving side. But I want to hear kind of your background as a physical therapist, and why another kid from our rural area chose to go into a health profession, and then just kind of tie it into leading up to the day that you have the four-wheeler drop on top of you.
Well, that's a long, long ramp into that story, because if we rewind all the way back to what made me think about becoming a physical therapist, it may be a little bit like what Lance said, where you can work with your hands, a little bit of the mechanics and physics of movement, but taken in connection with the patient healthcare side. And so that was something that really drew me to the profession at the start. The onset was that it was an opportunity to not only work with and get to know your patients, but also to help them recover from the worst days of their lives and get them back on their feet again. What is it? The old joke is, I wasn't sure the therapist could help me, but now I stand corrected. So
Nice.
I can think of countless episodes over the last years where it's just been so fun to see people return back to their basic, not only basic levels of function, but also like returning to sport, returning to elk hunting, whatever it is that they wanted to do, to be able to help them on that journey back. Now, obviously, it's part of a full interdisciplinary healthcare team setting, and so certainly the physical therapist can't do it certainly without any of the baseline help from the orthopedic surgeons, the primary care physicians, all the way across the team through nurses and wound care and the whole spectrum. But it is fun to be a part of that team and to really help people get back to what they want to do and what they need to do in order to have a fulfilled life and work and be a part of their families. Like it's really fulfilling to see that change in people. I've enjoyed that immensely over time. And you think about all the innumerable number of cases where people have had something just awful, whether it be trauma, whether it be some type of illness, stroke, heart attack, whatever it is, and just to be a part of that, the solution, and help them along the way. It's, I guess I don't do very much in skilled nursing anymore, but I was heavily involved in skilled nursing when I was working at the hospital. And anyway, I felt like a lot of my truest friends were there at the skilled nursing facility, like these old folks that were just so happy to see you and you're helping them. And I just remember that being a very fulfilling part of my career. Well, anyway, so fast forward a few years, I've helped people for over a decade with the physical therapy side of life. And anyway, just on a little four-wheeler ride behind my house, and I managed to roll the four-wheeler on top of me. And it was just kind of you'd think it was like in slow motion. We were only going like 2 miles an hour up a hill, but a little two-wheel drive four-wheeler rolled over on top of me. And I jumped out of the way, but it came down right on top of me. I put my hands and legs up to catch it. And just kind of like a hammer hitting a nail, the front rack of that four-wheeler hit the end of my femur and hit my knee and shot the femur out the backside of my acetabulum. And so that was immediately I knew something was horribly amiss. I was laying there on the trail. The four-wheeler righted itself, and I actually held on to the four-wheeler to keep it from rolling down the mountain. My wife was there on a second four-wheeler, and so she very calmly parked the four-wheelers, and I thought I'd fractured right in the middle of my femur. Like I was pretty sure that was the case. But as I was wiggling and wobbling around upside down on the trail. I think that's the only reason I didn't pass out, was because I was kind of upside down with my head lower than my feet. Anyway, so we were trying to splint it, hold it steady, and anyway, I determined that it wasn't a mid femur fracture; it was something up in the hip. So I was able to climb aboard one four-wheeler, and my wife drove us out. And Peter, you were there that night as well. We called and said, "Can you come get the gate for us and help us in?" And I was very, very appreciative of that, because transferring to and from the four-wheeler to and from a private vehicle and then into the emergency department, I was super grateful for everyone's help. It was, as Lance describes, maybe the worst, as far as trauma goes, worst day of my life ever when it comes to injury. And so the healthcare team there at the emergency department, they took really good care of me, loaded me up in an ambulance, put me on a fentanyl drip or whatever, and sent me all the way up to Idaho Falls, where I got to meet up with Lance. And so it was a couple of days before we were able to have the surgery, kind of waiting for some of the initial insult to calm down a little bit, and then had surgery a couple of days later. My wife, she was there at the hospital, and before surgery, she decided that I looked a little bit rough. I mean, I did look a little rough, and so she very carefully used a washcloth and washed off my face and head and everything, and it was just so dirty. I was just absolutely filthy because I'd been laying in the dirt and then transferred immediately. Like, obviously, not a lot of time for bathing when you're in the ambulance going back and forth, and so anyway, she thought I was quite filthy. But anyway, I was able to get cleaned up. We had surgery, and I don't know. It's maybe both of you had. I know, Peter, you've had this experience. Maybe Lance, you've had this experience too. But to go under the knife, under anesthesia, under the knife, and there's a lot of anxiety about that moment. It's like, holy cow! But it really helped to have a good healthcare team, folks to help me know everything was going to be okay. And like I said, I've treated many patients who have had this happen, and so I got to have that experience as well. And so anyway, went through recovery. My favorite part of my post-surgery recovery in the hospital was when the rounding doctor, this wasn't Lance, this was the rounding doc that came by, and I was just finally able to go to the bathroom, and I'm sitting there on the toilet. It's like the only 1 minute of the day I'm there on the toilet. And that's when the rounding doc comes by, and he's a great guy. And in my mind, he could have waited, go to the next patient and come back. But I know he's super busy. But anyway, I sat on the pot while he was doing his daily rounds, and I remember thinking to myself, "Wow, I've never had a doctor's visit while sitting on the toilet before." And so anyway, they finally discharged me, and I went home, and I was non-weight bearing for full non-weight bearing for 6 weeks, or toe touch weight bearing. Anyway, I got to know my walker and my recliner. Peter had a set of grabbers, little grabber that was super helpful. So had to have someone put my socks on. Like, it was a pain. And so actually, did we say it was full 8 weeks of non-weight bearing? I want to say.
I was going to say, I thought you were admitting to me that you may have broken the rules and started a little early, because I remember 8 weeks.
So it's getting a little bit fuzzy now. It's been 6 months post-injury. In fact, what's today? 14th. Yeah, so we just passed the 6-month mark. So it was 8 weeks, and I remember that at 8 weeks I was able to get into a pool, and I did some pool walking. That was really exciting, but at the same time disheartening, because the atrophy that had occurred around my hip was profound. And so I signed up and went to my first physical therapy visit to some of the guys. I used to be their boss, and went to my first physical therapy visit, and the PT, he thought it was quite remarkable, the lack of muscle mass around my hip. It was amazing how in the course of 8 weeks it had totally disappeared. And so we started getting to work on rehab, and anyway, we've progressed very steadily, and now I'm able to run a mile at a time on a treadmill and slowly working my way up. Maybe the part that's still a little disconcerting to me, but I'm still hopeful about it, is that when Lance came out of surgery, he said, "Yeah, we just had to hold your sciatic nerve out of the way while we worked on your acetabulum." And I remember having some feelings of like, "Wow, I'm very, very grateful you were careful with my sciatic nerve. I need that." And obviously careful with everything, but anyway, I've got some sciatic neuropathy down into my foot that is improving month by month, but it's just one of those things that has to take time. So anyway, maybe that's too long of a story, more than what you wanted, Peter, but it's it is. I would tease patients for a long time about how, I'm helping them after a total knee replacement or total hip replacement or after an ACL repair or whatever. And I'd never had any of those injuries or surgeries. And here I am acting like the expert on something I'd never done before. And obviously we learn and we grow and we have experience and certainly there's a lot of expertise there. But now I get the added expertise of having gone through it, having laid in that hospital bed, having gone through recovery, having gone through non-weight bearing and crutches and walkers and all of the like. And I, in the end, it has made me a better therapist, a better person all the way around. I, not that I, not that I would have, if I were, as I was drawing up my life, I probably wouldn't have drawn that into it. But as it is, I'm grateful for the experience and that has been an overall good, I feel like, in my life.
Yeah, well, thank you for sharing that. And, Lance, I want to kind of reflect back to you on this. So you've gone through this training, and on the doctor's side of it, you just have to when you or deal with somebody's trauma and emergency, you have to sort of put your feelings in a place where you're not too vulnerable. But it's kind of hard when someone from your own little hometown comes in and has been beaten up and shattered. And I'd want to hear kind of your experience of that. You get William Crane coming in on an ambulance and have to piece him back together. And I was curious, how you approach that. And like I say, Will's given us permission to talk about his case and how you approach the complicated acetabulum fracture on an otherwise healthy guy that had pretty bad trauma.
Yeah, for sure. Nobody really wants to operate or take care of somebody that they know or somebody that they grew up with or someone they went to high school with. Certainly not in the trauma setting, because that means somebody that you know and that you grew up with has been injured. And it's a tough balance, because again, by choosing to practice in a small community or a smaller area, those things are going to happen. You're going to be faced with that decision. And I think, and this is impossible, but I still think that the best way to approach that is that you have to treat everybody the same way. So if you start your career by treating every single patient that you see like they're Will Crane, then when you have to treat Will Crane, you just do what you've been doing the whole time. And that's easier said than done, but it's certainly something that I try to do. I try to treat each one of my patients as if they were a family member or a very close friend. And I tell people that I say, once I see you or once I consult on you, I consider you as a family member, and I will treat you that way. Now, that being said, when you treat somebody that you expect there to be something go wrong. I just expect that. I just know that because it's somebody I know, it's not all going to go perfect. It's not all going to go according to plan. And so you certainly try to take great care in that. And I can tell you that when we were doing Will's case, I had that mindset. I was like, all right, what part of this case is going to go poorly? Something's going to happen that's not going to go perfectly. And the approach, I felt went really well. The sciatic nerve, we were able to find it quickly and protect it. There was some bruising around it, which is probably why we're dealing with neuropathy, but it was intact. And that's the biggest deal for me, because even if the bones don't line up perfectly and you get arthritic, we can replace the hip. But if the sciatic nerve is torn or cut or damaged beyond repair, that's not something we can come back from. So I was super happy to see that was intact. We got down to the fracture, and it was a severe fracture. It's what we call a transverse posterior wall acetabular fracture, which is a bad player. It's a bad one to have. But that being said, I felt like we were able to get everything lined up, and we were able to get temporary pins in place, and it was looking great. We took some X-rays, everything's lined up great, and I'm starting to feel a little more confident. Everything's going smoothly. Maybe there won't be a problem. We put the first plate on and got it all secured. And then we put the second plate on, and as I'm tightening one of the screws, sure enough, nice, healthy bone was stronger than the screw, and we popped the head right off of a screw. Mm. And that is not a great problem to encounter, because there's not a great way to get a screw back out once you've popped the head off of it. So obviously there's decision making that you have to do, and you just have to, again, you have to do what you think is best for the patient and what you would do if it was your own hip or your own family's hip. And so we were able to redirect a second screw through that same hole of the plate and make it go around the broken screw. So we ended up leaving that screw in place. And in the end, as we were closing, didn't affect the construct or the alignment or the ability of that fracture to heal. So I guess if I had to pick a complication to have on a person that I know, it wasn't the worst one that you could have, one that we were able to get around. But then as he's gone through the process, I mean, he took you through it pretty well, but everything just kind of healed up just the way that we wanted it to. And it looks like at least 6 months out from now that it's completely healed at this point. And now we just hope that we get some longevity out of it. But you're right, it is a unique experience. You guys face it much more frequently than I do, because being in a community the size of the community you practice in, almost every patient that walks through your doors is going to be somebody that you know. And yeah, it's an awesome thing, but at the same time, it's a unique challenge that is not simple or easy to overcome, but just has to be planned for.
You know, it's interesting you say that, Lance. I perseverate and worry about that all the time because, you know, because I'm in a small community, I'm like, well, probably going to see the same person I'm going to see him at the grocery store or at a sporting event or church or something. There's going to be some other interaction, and I want it to be positive. I don't want him to be like, oh, there goes that rotten doctor that, you know, did something that I don't like. But I thought, and maybe William, you can comment on this too. When we knew, you know, because I know there's just a limited number of orthopedic trauma surgeons in our region. When we knew that it was Lance Jacobson on the receiving end of that, as family members, as a, you know, primary care doctor, I was just so pleased. I'm like, hey, this is a person who I know will take care of my brother, and it's going to be okay. And I didn't worry about it for a moment after that. I'm like, he's in good hands. Well, it'll, you know, you can't guarantee good outcomes. Nobody can. That's impossible. But I think attentiveness and focus on that personalized care and saying, just like what you said, Lance, like that I would treat this person with the utmost care no matter who it is. I think that goes a long way. William, I don't know what your thoughts were. You were probably sedated a little bit at that point. I don't know if you remember very much.
Well, the similar thought there there's I guess I'm trying to figure out how to put it. But there's a level of trust that you can have when there's a known quantity on the other end, in the sense that, you know, if I were transferred, you know, let's say you flew me out to Houston or something, there was some ortho trauma guy that was the best ever in Houston, and I don't know that person, you don't know that person, just a name on a page, there's a little bit of question mark there. But like Lance's dad was my boss for the first, he's the one that hired me at the hospital at the start, and I guess it felt like a little bit more of a known quantity. You can take the anxiety levels down a little bit because you've got some familiarity with the person and what it is that you're getting yourself into, and then that level of familiarity hopefully is based in a trust that is not unfounded. It's a trust that comes from getting to know people. And anyway, when you were talking about that, it just reminded, I tease you all the time about how you have patients who come up to you in the grocery store or in the hallway at church or something. It's like, hey, I got this weird rash. Let me show you this weird rash I've got. and I think it's because they know and trust you. Like, it's not, I don't think they realize that it's kind of an inappropriate place to start showing off strange rashes while you're picking up the pasta in the grocery store. But in any case, I think it does reflect, though, on the trust and familiarity that they have, that they know that whatever you say is gospel truth, and they are going to be super, super anxious to hear what you have to say. Now, maybe you don't feel that way because some of the time they don't do what you tell them, but maybe not just some of the time. But in any case, I do think that trust that comes from familiarity and treating everyone like family is well-founded.
No, I think it's an interesting experience, but I just thought about it, Lance, because, you know, as a doctor, my normal experience where I work is that most of the patients will know who I am, or the majority of them know who I am, or they've had some interaction with me, or they've had a family member interact, and I am always kind of nervous about that. I want them to I don't want to disappoint them, or I want to do a good job. But I'm just telling you from a family member standpoint, when Will had a really terrible trauma, it was amazing to the amount of peace that came. Like, oh, well, we're sending Will to someone that I know and trust, and it was interesting to be on the patient side of that, because it's not something I've experienced very much on where I'm sending a close family member, to a specialist.
Yeah, I mean, I hope that nobody ever has to be in that position, but unfortunately, it happens on a daily basis, and that goes back to that unique opportunity of meeting somebody on that fateful day, or the worst day of your life, or at least the worst one of the worst days of your life. And it's a hard thing as a healthcare provider that you have to realize that even though that's probably the 17th trauma you've seen on that day, and probably not even the worst one you've seen that day, it is the first time that this patient and their family has ever had anything like this. And it is the worst time, it's the worst one that they've probably ever had or seen. And you have to almost, you almost have to remind yourself of that every time you go in to see them, so that you don't come off as jaded, or immune, or just calloused and cold, because that's a hard thing to do, because you do get calloused. It's
Right.
something I see every single day, and you have to step back and say, okay, I need to realize that this is their first time, and I need to try to, because they don't know, a lot of the times they don't know me from Adam. You guys had the fortune of knowing who I am, but they don't. And I get 10 minutes to instill that same trust that you had, and that same peace that you had. I get that 10 minutes to instill that trust in me, and hopefully make them feel that same peace with me as their family member's physician.
Yeah, no, it's an interesting experience, it's all the way through. One of the things I wanted to ask you about, Lance, is you must have a special technique, because I noticed that the Will was able to drive his ADA approved swather within your first 8 weeks after the trauma. I came back from Yellowstone Park and I saw the swather up on the hill kicking up a dust, cutting hay, and I'm like, who's in our swather cutting hay? And I pulled up and there was Will, and he's like, well, the swather's practically ADA approved, so yeah, William, you ought to share that story, because
Well, I mean, it feels like not that big of a deal, but you do get stir crazy sitting around, and the pain had started to subside a little bit. It's still bouncing around on the swather didn't do much for my pain. Let's be honest about that. But it does have an air ride seat and good rails, and I was able to hop up into the seat. So once I using two hands and a single hop, I hopped up the little stairs up into the cab. From that point, there was no foot control at all. It's all hand controls. And so on an air ride seat, hand controls, I felt like that wasn't too big of a deal. The only trouble was if there was any breakdown or trouble. And so I had my son with me, and I knew that I had some other people that were kind of a phone call away, but I just
yeah, just Walker propped up against the front window of the swather.
Well, it made perfect sense to me. I didn't see any big issue with it, and having done enough, as part of rehab, you help people get into and out of vehicles, up and down stairs, in and out of their homes. I felt like I had a particular set of skills for non-weight bearing entry into a cab of a swather.
This it's certainly a unique experience, but I will tell you that in the area that we live, there's a number of people who've had similar. And I think that's part of where we live. Just because you have a trauma doesn't mean life stops, especially when it comes to running a ranch or a farm. There's only a limited number of hands or help, and there's not really the advantage of a FMLA where you can just say, hey, I'm going to get paid to not go to work, which we're grateful when we have jobs that do have FMLA, but that's not a ranch and that's not a farm. So I've had patients who've used front end loaders to load them, have their son or their family member load themselves into a swather
Yeah.
without, so they can avoid putting weight on it by getting loaded by a front end loader, just to keep getting to work.
That's funny. Yeah, so William and I run that farm together. So the only person that could have signed your FMLA papers would have been me. So we had been on the trip, and I came back that on a Saturday afternoon, and I just can't. I just saw this whole big pile of dust over there where the swather was going back and forth. I couldn't believe it, but I figured you had some fancy technique, Lance. If your patient was up there in the ADA approved swather in those first few weeks, that's a testament to a surgery well done.
Right.
No,
Hey, but I maintain my weight bearing precautions. Just so you know, I was
Oh, I know.
I was a very compliant patient, but I was up in a swather, so I don't know. Maybe I'm speaking out of both sides of my mouth, but it was
Well,
it was nice to get out.
and I can think of multiple patients. You can too, Lance, and you will, like where people have done a hip replacement, in their late 80s, just so they can get back on a horse. I can think of several people who are like, well, I'll do this if you think it's a good idea. I guess I'll get it done. But how long till I can get back on my horse or my tractor? And sure enough, they do. Fast forward just a real short window, and well, it was time to go get the cows. So they were back on the horse and with a brand new hip in their 80s. It's impressive, actually.
Yeah.
We'll talk a little bit, Lance. I want to shift gears just for a second one of the things we talk about on this podcast is kind of the freedom, or I guess the better quality that I think doctors can provide patients when they're not motivated by financial debt. Because I think that becomes a real problem for people, is because they go and they're in so much debt, and then they say, well, I have to do X, Y, and Z at my job, or I have to work in a place that's really not good for my health or my family because I'm in so much debt. And I was curious if you had any experiences along the way of things you would do or you would not do on that. As you're talking to again, a group of doctors, a lot of them who are in training right now. How do you avoid some of the pitfalls, and what are some of the advice you would give?
Yeah. That's a super hard thing. And I can tell you that you go through all of that. I mean, that's 13 or 14 years post high school that I went through, of being poor as a church mouse and not having nice things that you want to have. And especially when you've got a young family, as we chose to have our family fairly young, when you do that, it's financially difficult for sure. And you come all the way through that, and you finally get into your attendingship or your practice, and you start to make pretty reasonable money. It's hard to keep the restraint on what you purchase. And I'd say that's the biggest thing that I learned the hard way, is you've learned how to be so frugal and live without some of the nicer things, or they're the things that you don't need, the things that you want. And you suddenly get this money and you start spending it like it's burning a hole in your pocket. And I certainly would have been better off in the first few years of my practice if I would have showed more restraint in the big purchases. I mean, obviously, the going out to eat here or there, or treating your spouse who's been through 13 hard years with you to a nice birthday present, that's not going to make a big difference. But I would say buying a home, when you decide to buy a home, if that first one can be a little more modest, instead of saying, hey, I've got to get the home that I'm going to live in for the rest of my life. And that's one of the mistakes I'd say we made, is because we're already in a huge amount of debt from school. MCW is a private school, so that means that it was a little more expensive than a public school would have been. So we had that huge debt, and we added onto that a mortgage that was bigger than it probably should have been. And so now I've got two debts that I've got to pay down. And you're right, it makes you start to wonder about, well, should I start to pick up some locums work so that I can make more money, so that I can to pay off these things? And that thought certainly crossed my mind, and I had that opportunity. but that wouldn't have been what was best for my family. Me being gone more than I already am would not have been in their best interest. And so then we had to make other decisions, which we did, that helped us to pay off the debt that we had. And we've, in the 7 years, gotten now to a more comfortable position where you don't feel that debt hanging over the top of your head. So, again, I had heard that advice. The advice, the way it was said to me was just live like you're still a resident for a few more years, and you'll be completely free of debt, and then be able to start to grow financial independence. And that's something that I wish I would have listened to better.
Yeah, well, and I think it's easy because it's the same story. By the time you finally have kind of your real job, you're well into your 30s. And one of the things that I reflect on now is most of my college roommates, friends who had a similar education level and aptitude and all that stuff, they started earning a decent income when they were 23, 24, 25. And so if you fast forward and say, okay, I don't have the time value of money for a whole decade, and they've been able to invest and let whatever they did invest grow at a slow, steady rate. Just if you invest in an S&P index stock market fund, it on average has grown about 10% per year for many, many years. And so if you put a little bit in there, it makes a lot of difference over a larger time horizon. But when you chop 10 years off that time horizon and you come out and you're like, okay, well, my income is such, is this number, so maybe I can afford that. It looks, there's quite a difference between income and wealth. And I would say at the beginning of my attending years, we had zero wealth, just broke. And try to live carefully to try to get back to being actually just broke, by the time we're in our 40s. And I think it's an important thing to remember. The reason doctors, I think, kind of get trapped in that is because you say, well, all my peers have got a house and they've been saving and they're on track for retirement, and doctors really aren't. Like, they start off and you say, look, I just have nothing but a piece of paper that says I've got lots of training and I've got this income potential that I've bought, and if I play my cards carefully for the first 8 to 10 years, then you're back to broke and you can try to catch up with what your peers did. But I don't know, it's quite an experience, and it's such an easy trap to fall in. And one person told me that MD stands for money dumb, D-U-M-B. And I think it's because you get no training on finances, really. You just come out and you're so busy in residency, you're so busy in your attending years, like, I don't know, just buy it and stop bothering me with it. Yet if we don't maintain that stuff, it's crippling to a career for sure.
Yeah.
Will, do you have any comments on that? Physical therapy school is, of maybe not quite as long, but a similar thing. You have to put on hold some of those things that you would have maybe purchased in your 20s.
Certainly. So everything you've said is certainly in many ways equally applicable to the physical therapy career. The one that I see that, so I feel fortunate that this didn't happen to me, but I see people now coming out of PT school with a debt load from just PT school, their housing and all the other supplies and books and everything. They come out with a debt load that's somewhere in the 4 to 5x of their first year salary.
Holy cow.
And you look at that, you're like, what are you thinking? I mean, PTs are not orthopedic surgeons. I mean, let's get that right. That's the income earning potential is not the same. It's apples and oranges. No matter how much people love to talk about the DPT and how, the profession is growing and our career responsibilities are increasing. So we've transitioned from a master's level program to a doctorate level program. Great. Okay, so we got all that great training. The income potential did not change. And so they added more schooling and more prestige and more letters, but they didn't actually add any income potential. And so that's one thing that I see students coming out. I just am in shock. And I as far as advice, I would advise to cut down that debt load as much as possible, which probably means choosing, school choice is probably the first on the list of how to cut the debt load, especially for PTs where the earning potential is not not nearly the same as physicians and surgeons. But so school choice, but then secondarily would be your choices during school to, as best you can, try to cut the amount that you do have to borrow, how to choose. So in PT school, we have to do these clinical internships where we go and we have essentially about a year to a year and a half of in-person hands-on training with a licensed physical therapist. Now, the choice of where you do that makes a difference. That you could do it close to where you've got housing available, is probably family related, versus you could choose a place where it's quite expensive to go live and rent a second apartment for 6 months. Like, there's choices you can make there. And then once you're out of school, making choices about where you choose to work that have income, or not income-based repayment, but student loan repayment options that are an extra benefit. So you can make a lot of choices about from the start of good schooling. And those of you who are listening to this podcast are probably not in that boat, and so now you're on the back end side of this. But making choices that reduce the amount of outgo. And this is just like, I think this is the same for orthopedic surgeons and physicians, that if you just live like a student for a couple extra years, you can make a big dent in that debt load. That, again, I still can't get over the shock of 4 to 5x your earning potential in student debt. It's like, man, that is crushing when your income potential is just not that high. And so anyway, long story short, I wasn't absolutely crushed by the debt, but I was motivated to get out of it as quickly as I could. And that's why I started a business. And that's why I started PT Final Exam, and I do online education. And that, in combination with my regular clinical work, that was one of the things that was really gas on the fire to get rid of some debt as quickly as we could.
Yeah. Well, we all graduated from the same small high school. And Lance, I don't know if you heard this advice. I think William heard it. Somebody told me once, never borrow more than you expect to earn in your first year's salary, no matter what your job is.
I heard that advice too.
Lance, I don't know if you ever heard. Did you ever hear anybody say that?
Yeah, I remember hearing that.
I don't know where we got it, but I'm so thankful for that advice, because it doesn't matter what your profession is. The math has to work for everybody. And it's true. And I've observed, just like what Will alluded to, I've seen people choosing to do whatever profession, and they're taking it something that's multiple times what their earning potential is. And my oldest is in the college years, and we're trying to kind of talk through that a little bit. It's like, well, you can borrow money if you need to, but be real careful so that you don't break the math. Because if you do it wrong, you're just in debt up to your eyeballs for decades to come, and it's pretty hard. Well, Lance, do you have any other final thoughts as we kind of wrap up here as for our group? I really appreciate you taking the time, and I think it's fascinating to hear what you do and how and your approach on that.
No, I just appreciate the invite to be able to do it. It's certainly a unique opportunity to reflect back and to see, the successes. And I think I think the biggest thing, for me, for the listeners of your podcast, is just that to think about what your earning potential is. And I mean, they're probably already accepted the debt, but I feel like I want to just make sure they know that there's more than just the financial aspect when you're making that decision, because I had an opportunity. I could have made a lot more money living where I did my fellowship in Indiana. Had an opportunity to make a lot more money, and it would have been more financially beneficial to me, but it wouldn't have been 2 hours away from where I grew up. And it would have compromised the goal that I had set when I went into medicine. And so, there might be some sacrifices that you have to make financially to benefit both your patients and your family. Yeah.
Well, and I think one of the reasons that we do this is just to highlight the big difference that people make in the lives of patients and families. And I've been a patient on the receiving end of that, and I know Will has, and probably most people at some point in their lives will. And I'm so thankful for doctors that have spent countless hours. I mean, literally thousands and thousands of hours to hone their craft and to become good at it. Lance, that was something that William and I reflected on a little bit, and our family. When you were there, when the time called, I mean, it made all the difference. It was just so great to say there's someone that's has dedicated many years of his life so that when this moment of crisis hit, you were ready. And I think it's awesome to talk to you and to other doctors. It just makes really this big difference. And it sounds abstract until it's your family, and you're like, okay, I am so thankful there's someone on the other end of this, a real human being that spent thousands of hours of his life to be able to become good at something, so that I could, when it was my turn to need help or my family's turn to need help, they were there for me, and I think it's pretty cool.
Yeah, for sure.
Yeah. Will, do you have any other final thoughts on this as we wrap up here?
Well, if you'll indulge me, I'll share one final little thought here that has been formative in my life about the title of this podcast, Doctors Making a Difference. So I was in my training, and I had one patient who this experience it strikes me so much as the difference between someone who makes a difference and someone who doesn't make a difference is that a patient was laying. We were in the ortho floor at the University Hospital in Salt Lake, and as Lance says, just kind of the worst time of their lives. And so this person's laying in a bed in the ortho floor, and the doc comes in. In a teaching hospital, there's kind of not a thundering herd, but it's kind of this steady herd of interns and residents and fellows and everyone. They go around, and anyway, the main doc comes in, and it's that very quick visit, and obviously they're just making the rounds, and that's the way it is. But
not on the toilet.
Yeah, this patient was in bed. They were in bed at the moment, but they had a question. They're like, my neck, something feels funny about my neck. And so the doc comes over and just kind of, looks down his nose, kind of spectacles, and says, just fasciculations of the platysma, and then walks out the door. And the patient had this look of terror, like, am I going to die? Like, fasciculations of the platysma. That sounds awful. And anyway, the point that was driven home in my mind was, and this is what both of you, as my physicians, have done, that you put it in terms that the person will understand. Now that could be different for every single person, but I think that's what makes a difference, is that you speak to them like you would to someone you want to communicate with, not just someone that you want to describe fasciculations of the platysma and walk out the door and leave them wondering what in the world you were just telling them about. Instead, I feel like the desire to communicate what it is that they need to hear and what you want to tell them. Obviously, you're communicating things that are important, critical in every aspect, but in a way that they'll hear it and understand it and know that you care, that they are sitting there in the bed or on the toilet or wherever they are, that you are there to make a difference in their lives. Anyway, that's been very formative in my practice, that I try to remember pretty frequently that experience of fasciculations of the platysma, to know that I need to make sure to put it in terms that they'll understand and that will be meaningful to them. Which it doesn't mean that we're like dumbing it down or putting it, sugarcoating the thing, but you are communicating it clearly in a way that they'll hear you. So anyway, that's one of the biggest ways I've seen doctors make a difference, is that communication skill. And so then that's what makes them want to come up to you in the hallway after Sunday school to ask you about their strange rash on their arm.
Well, and I think just to kind of reflect on that just a minute, when I think about why I became a doctor, but maybe more importantly why I'm still a doctor, and I spent, Lance, you can probably think of that, why I still do this and why it's still important now, more than a decade into my career. It's that the thing that keeps me getting up every day is to help patients. Like that's really what drives it. That's those unique experiences. Everybody's story is a little bit different. Everybody's chapter is a little different, and I'm fascinated by that. And to be in a privileged position to sit and help somebody and explain a challenge and help them through a hard time, it really is kind of a unique and rare privilege to do that. And I still celebrate the idea that we can do that. And Lance, I'm assuming you kind of have much the same.
Yeah, I think it's a unique trust that we get, that's placed on us, that can never be taken for granted. I'm always intrigued. I can walk into a patient's room having never met them, and they will pull the covers up and let me touch their feet, right? Because they got an ankle fracture and I need to look at the ankle. But who else would you ever, if they walked into your room, pull your covers up so they could touch your bare feet? Like it wouldn't happen. But that unique patient doctor relationship gives them that trust, that they're willing to do that, or they're willing to sit there on the toilet and let you talk to them, right? Like that's not something that would happen outside of a doctor patient relationship, and you just can't ever forget that. You can't forget the trust that's being placed in you as a physician or as a provider.
That's great wisdom. Well, hey, I appreciate both of you taking the time to do this discussion. I've really enjoyed it. It's fun it's kind of like a little reunion of people that went to the same little teeny high school, and I hope we're all doing some good in the world. And Lance, specifically, thank you for putting Will back together. He was kind of like Humpty Dumpty there earlier this summer, and you put him back together, and he's doing so much better. And
Will, thank you.
Yeah,
big thanks there.
It's been my pleasure.
Okay. I think it was the donuts. We brought Lance donuts like post surgery, and that was
definitely the donuts.
I'm sure that was it.
Oh my goodness. And the ADA approved swather. Oh my goodness. What a cool story. Well, I'll catch up with both of you later. Thank you both so much for doing this. I appreciate it.
You bet. Thanks, guys.
Yeah, take care.
Thank you.